what kind of neoadjuvant chemotherapy do you recommend for your patients who have HER2 positive breast cancer? Do you ever give less than ACTHP or TCHP?
I usually give the full TC for people who are T2 and above and or N1. They'll get TCHP. I think that we have learned, though, I think from analogies to other smaller studies that have been done by the German group, as well as, at least in the metastatic setting, that we probably could think about cutting the carbo if you really had to. I wouldn't do that if I had a choice. I think, as Ian said in his patient, I would definitely think about cutting the pertuzumab if I have to for a cycle or two, because diarrhea does seem to be bigger than I think a lot of us would have thought with this regimen, at least in my experience. You know, in mine, it's probably about 9, 10, 12%. I think it's about right. But generally, I try to do TCHP up front. And then I think, as we're going to talk about in a minute, if not, what to do after they have or done with the therapy in terms of their response, I think is a big debate. Not much of a debate, but I think that's where the real debate is right now.
Well, I mean, it's a sort of a data-free zone in many ways, but I think that's interesting. Ian, do you also use TCHP usually as your backbone, or do you use a different approach? And is there a patient specifically where you might, for example, give THP and then make a decision?
Yeah, so I think that's another area of real interest because we know that giving just THP is associated with a pretty significant PCR rate. And there's actually a large trial that's just getting underway within the US cooperative group system that's asking that specific question. Can you treat patients with moderate to high risk HER2 positive disease with just 4 cycles of THP, and then if they have a pathologic complete response, not add any additional chemotherapy? So it's a true de-escalation design. If they don't have a pathologic complete response, then it's recommended they get additional chemotherapy in addition to the TDM1. So I think my personal feeling is that outside of a clinical trial, right now the standard is just what Adam was saying, which is using either TCHP, or we still use THP in some patients. But I think there's a lot of interest in trying to cut back some of that chemotherapy, since we know that some of the, not only some, a substantial fraction of these patients are going to have very sensitive disease and will have a pathologic complete response just with a taxane-based regimen alone.
Is there do you vary what you're treating patients with based on their hormone receptor status?
I typically don't, even though we know that that affects the pathologic complete response rate. I've mainly based it on overall risk.